Radiation is changing quite quickly. Our environment is changing rapidly. Our treatments are changing rapidly. Everything about how we deliver care to our patients is evolving really at an accelerated rate. I think an unprecedented rate right now compared to where we've come from over the past 50 or 60 years. And I'm sure everyone is familiar with these kinds of pictures. One of the original Cobalt-60 units with some of our predecessors from our physics communities sort of 60 or more years ago now, somewhere in Western Canada being developed, to the kind of technology that everyone has in their clinics today and exploits on a daily basis to benefit our patients. And this evolution has happened with varying rates and in varying ways over the last number of years. But in general, it's been associated with increased conformality, our ability to deliver dose much more conformally and with much more certainty to specific targets and patients. Along with that has come inherently increased complexity in how we deliver care. And these two together, I think, have resulted in improved outcomes for our patients. And if you look across the spectrum of types of cancers that we treat, I think there is evidence of that, either evidence in terms of local control, curative potential of our treatment, or even greater effectiveness in how we palliate pain and bleeding and other symptoms for our patients. And this, of course, is just an example of the kinds of distributions that we're now able to deliver to our patients. I treat a lot of gynecologic cancer, as Jean-Pierre said, so I've got a few examples in this talk of patients with gynecologic tumors. But this applies to any treatment site, and the idea is that we're able to sculpt our dose distributions much more precisely. And areas of concern before we were able to do this, when this was treated with a standard 4-field box technique, now bubble to the surface. Areas that were not so concerning before now become things that we have to worry about as part of the treatment team to be sure that we're delivering optimal care to patients. And I think this is going to continue. If I actually look to the future and say, where are we going to be in 10 years, 20 years, how are things going to continue to evolve? I think that this is the kind of paradigm that I would like to see. A real focus on continuing precision treatment, high precision treatment with external beam radiation, stereotactic techniques. Brachytherapy, I think, has huge advantages to offer patients under the right circumstances. But I think it's going to change in that we will no longer assume that the target we see up front when we start radiation treatment is a relevant target 5 weeks into fractionated treatment. I think there's going to be an increasing emphasis on adaptive radiation treatment, and we as a community need to embrace the concept of changing our plans as treatment evolves over time. An entirely different paradigm for how we deliver care, and a lot of big implications in terms of the quality assurance and safety to our patients as that happens. We're going to continue to very much personalize our treatment, not just with respect to the radiation we deliver, but radiation will integrate in an increasingly in increasing manner with surgery and chemotherapy and new targeted molecular treatments. So as radiation oncologist, my job is going to become less about planning the treatment and delivering that care to the patient. It's going to become more about talking to my colleagues in surgery, talking to my colleagues in medical oncology, understanding molecular pathways of disease response to radiation, and really modulating how we provide that care at that level. I think we're going to be, despite that, technology-driven, but I hope we stay evidence-based. In other words, that we are not solely driven by technology, that the technology is a tool that we can capitalize on and exploit, but that the driver for patient care is scientific evidence, clinical trial evidence, or similar sorts of things. We will see, I hope, increased uniformity of care, so that in Canada, a patient treated in Vancouver for a particular disease is treated the same way in Toronto and in Halifax across the country. If you think about it, there should be no reason, the evidence is the same everywhere, there should be no reason why there are different standards of care, different levels of care as a function of geographic location. And in order to drive this forward, we're going to need an increased emphasis on quality and safety, because if we're not delivering care in a high quality manner and a safe manner, we're actually doing our patients a disservice potentially rather than helping them. So some of the complexity and uncertainty that we're going to come up against. We have increasingly complex patients. The problems are complex, the treatments are complex, integration of surgery with molecular therapeutics, for example, and how we sequence those things is going to become increasingly challenging. We have complex technology. We have a complex multi-step treatment process that we all are aware of. And we are hugely dependent on professional interdependence. I can't do my job by myself. I can't treat a patient by myself as a radiation oncologist. I am hugely dependent on my colleagues in medical physics and in radiation therapy and in nursing and all the other disciplines to provide comprehensive care to a patient. And that's only going to become more prevalent, more prominent as we move forward along the lines of what I just was talking about. I think we're going to see role differentiation, that we're all going to move off and do things in a slightly different way. I'm going to spend more of my time in the clinic talking about integrating radiation with other types of cancer care. Radiation therapist role, I think, will evolve towards contouring and planning and all sorts of other things. So there's a real space shift here that's happening right now that we need to be aware of. Of course, we all are in a situation where research and innovation is always there, and that can range from a new piece of technology coming into our clinic and how we manage that to environments like this where there's always new things coming along in terms of technology or imaging or new drugs or trials that we're layering on our patient population as they come through, and everybody wants everything done quickly. If we always want to treat more patients with the same amount of money in less time, and that pressure for throughput also is challenging. This is an example of the kinds of targets that we're dealing with now in a patient with cervix cancer that when I first started practicing, no one even gave this a thought because of the way in which radiation was being delivered. But if we think, first of all, where the target is located, the kind of imaging modality we have available now, MR layered on planning CT, PET layered on top of planning CT to identify relevant targets. Once we think we know where the target is, we ask a bunch of radiation oncologists to try to contour that target, and it's all over the map. So even when we have good imaging, there's a spectrum of opinion among very experienced oncologists about what should be treated in a particular circumstance. Those contours in the middle are from 20 experienced gynecologic radiation oncologists from around the world, the people who are publishing in the Red Journal and the Green Journal. They were sent an MR and asked to contour the cervix and the parametria on this patient. And this is the kind of variability that is seen from people who think about this all the time, every day. And this is in cervix cancer. You can find similar studies in head and neck cancer, lung cancer, you name it. So as a community, we need to come together and figure out how we're going to harmonize these sorts of practices and the sorts of contouring and really address these uncertainties up front. And lastly, we have all the issues of movement that we would have previously ignored in a case like this, a woman with cervix cancer being treated with a 4-foot box. But even if we image appropriately up front, figure out where the contour should be to delineate the target appropriately, the target then moves around from day to day, even moves around during the time the treatment's being delivered. So how do we accommodate all of those uncertainties into a plan to assure that we're delivering optimal care? And it actually does make a difference if you think about how we integrate all of that information. And I think you'll see this image later on in the session over the next couple of days. But it speaks to the point that the quality of care that we provide patients upstream in terms of planning, appropriate target delineation, appropriate volumes is very, very important. This was a randomized trial of radiotherapy and concurrent chemotherapy in patients with head and neck cancer. And the difference between the arms was that patients were either randomized to get standard of care or standard of care plus a novel targeted agent that happened to actually target hypoxia. That doesn't really matter. But at the end of the day, there was no difference in this randomized trial. It was a bit of a disappointment. The study team went back and looked at, retrospectively, the quality of the radiation prescription for these patients. And they divided it out according to patients who had either a good plan to start with, a good plan, or a poor plan to start with, but with feedback to the institution it was fixed so that the plan at the end of the day was appropriate. And there was a third category that I don't remember. But that's these three curves at the top here. Those patients who had actually a good plan to begin with or a plan that was problematic but fixed had hugely different outcomes compared to patients who had a poor plan that was never corrected. And the magnitude of this difference, almost 20%, is far greater than what they would have ever seen with the addition of this drug. So it's important from a clinical trials perspective. It also speaks to our outcomes for our patients if we are not always delivering optimal care to these patients. And that just doesn't speak to issues around appropriate throughput through our system and all the checks and balances that we do and beam calibration and all of that. It speaks to what happens right up front at the level of radiation oncologists when they're thinking about planning these patients and delivering care. We have this complex technology. Once we've got this planning system in place, once we've got the plans developed, once we think we've got a good plan, we have to execute it. And of course, the technology that we use to do that is hugely complex. And it doesn't talk to, one piece doesn't necessarily talk to another piece all that well at this point in time. We have different vendors with communication systems that are supposed to be compatible, but they don't sometimes connect. There are activities ongoing, as many of you know, to try to link the communication across vendors, and there are connectathons that are held at Astro and other large meetings where vendors come together and try to demonstrate that their product will talk to some other vendor's product. Those kinds of things are important and are going to be increasingly important. And I love this slide. It came from John French, who's a radiation therapist in Vancouver, and it just illustrates that we've got this complex technology, we've got the complex interconnections of the technology, but one of the important bits that is only recently, I think, being addressed is the interface, the user interface, the operability of the equipment in the context of delivering care. And this really speaks to the kinds of interfaces that until recently our radiation therapists were asked to deal with. And if you just look at the number of monitors and screens and keyboards in that image, 2 therapists are expected to integrate all of this information at the same time. And vendors now are becoming aware of this and are starting to think about how can we do this better? How can we put information out there in a way that is easier for people to assimilate and make decisions and use appropriately. And of course, we also have a complex flow. Jean-Pierre gave me this image, which shows sort of a flow path through one of our treatment processes. This happened to be for a new bit of equipment, an MR-guided linear accelerator that's being developed. But from e-booking all the way through to the delivery of the last fraction, multiple steps and checks and balances have to happen in order for the system to perform appropriately and for care to be delivered in an optimal manner. Finally, the innovation piece, I think we can't underestimate, and this speaks to something that I mentioned earlier, which is the concept of adaptive treatment, which I think is coming quite quickly as one form of innovation, and the concept that we need to actually start thinking about what happens during treatment as our fields become more conformal, as our treatments become more conformal. These issues about tumor regression during treatment and volume changes and positional shifts and changes in shape can have important dosimetric implications and therefore potentially also important outcome implications for our patients. And this is another one of our studies in patients with cervix cancer where we did dose accumulation over a 5-week course of treatment and developed a dose difference map compared to what we thought we were delivering for those patients based on the planning CT up front. And there can be, under some circumstances, substantial variation that, as I say, can either contribute to poor tumor control, impaired tumor control, or increased levels of side effects for our patients. So to sum that all up, I think that radiation is becoming increasingly effective, I believe. I think it's a great treatment modality, something that we will continue to use to great effect over the next little while in our patients. I don't think it's going away. It is becoming increasingly complex, though, and it's demanding, therefore, of an increasingly high level of oversight to assure optimal system performance and clinical outcomes for our patients. And that's really the focus of why we're here today. So the World Health Organization talks about quality assurance, and they define it as all those procedures that ensure consistency of the medical prescription and the safe fulfillment of that prescription aimed at determining the end result of treatment. So this applies to radiation treatment. It applies to a wide range of other medical interventions as well. It's key, though, I think, to recognize that when we talk about a quality program, a quality assurance program, and quality control, that all of that needs to start not at the level of program leadership. It needs to start at the grassroots of every cancer program individually, out there in Canada or internationally. And this is something that came from an ASTRO publication in 2012, Safety is No Accident, and this is a publication that really was driven by some of the accidents that occurred in the US back 5 or 6 years ago, and the sort of response to that by ASTRO and AEPM and the radiation treatment community broadly in the US to try to improve quality and safety and actually get messaging out to the community as well that this is happening and that radiation is a safe treatment. But the emphasis really is that it needs to start at the level of the grassroots individuals, the oncologists, the radiation therapists, the medical physicists, and others who are delivering care for patients, to patients. And there are several ways that that can happen. Program leadership merely supports that and nurtures it and rewards the kinds of things that happen. And also, of course, monitors response. And I think this is fairly fundamental to having effective quality control in any program. And it really drives a cycle of continuous quality improvement. And over the course of the next couple of days, you'll hear about the Deming cycle and other quality improvement strategies. But the concept of measuring something, analyzing that result, developing a response, implementing that response, and then measuring again to be sure that what you intended to achieve is achieved will be something that comes back and that you'll hear about repeatedly over the next couple of days. I think it's very important also to recognize that we're all working in a resource-constrained environment. And when we think about the various pressures on us as individuals or on our programs, I like to divide them into 3 broad groups that are shown there. First of all, we have the clinical workload issue, the time pressure, those sorts of things. We need to get stuff done. We need to get patients through the system. If we're not doing that, we're not effective, we're not delivering good care to patients. We also need to assure that at all times the quality and safety is appropriate, that patients are receiving high quality care, and we need to manage the complexity and innovation that we've just been talking about. If we had infinite resources, this would be very easy to do because you just shovel more money, more people, more machines, more whatever you needed at it to make sure it happens. In fact, none of us has all of those resources, so we're always balancing things. We're always saying, what can we trade off to accomplish something else? And we see this play out in real practice in very interesting ways sometimes. So within our program, for example, I know that when we're stressed in terms of patient volumes or complex care, a lot of complex patients coming through with particularly difficult plans, or time pressure to get a particular patient onto the treatment unit, if we stress that direction, that arrow, more than the others, we see some of these other things fall down. So that's when we tend to have errors happening within our system. We can actually document that quite clearly, that in times of stress like that, we're more likely to have errors arising. So how we build in recognition of these kinds of complexity and actually compensate for them dynamically as they're happening, I think is one of the challenges that we within the radiation community have to address, but it's true of many complex industries as well. And coming back to that point, if we have an imbalance in our system, we sometimes see these kinds of things happening. And this was a real error that happened here not long ago. It's a fascinating discussion. We can spend a lot of time talking about it, and you may in fact spend more time talking about it over the course of the next couple of days. But this particular patient who had locally advanced lung cancer was receiving curative treatment, and actually at the end of the day received a small amount of received dose to a small volume right there. Received full dose, 66 gray, to that volume, completely inadvertently. It propagated through our entire system of checks and balances and was delivered in its entirety and was only picked up after the fact by a resident who was doing a quality assurance review of experience in relation to a research project that she was doing. And then said, why did this patient get dosed? And so it's a fascinating discussion around the type of error it was, how it happened, what we could have done to prevent it, and why it propagated through the system. And I think you may well come back to it. Yes. But I use it here to illustrate the fact that these things happen regardless of the systems and processes that we have in place. And we need to respond to those things when they do happen. The public is aware of these things. The public is very much aware of the fact that errors can happen in radiation treatment and sometimes can be quite significant. These are the sorts of things that were published about 4 years ago now in the New York Times, talking about very serious medical incidents, medical errors in the United States. And if you go online, you don't have to search very far. If you do a Google search, you'll get stuff like this popping up about radiation treatment. This was, again, around just after those events in 2011, and they talk about the top 10 health technology hazards. And number 1 on the list, radiation overdose and other dose errors during radiation therapy. And if you just blow that up, you see the kinds of things that our patients come across or can come across. Radiation misadventure during radiation therapy can have devastating health consequences, from causing critical damage to normal tissues and organs, which can lead to severe morbidity and death, to creating an avenue for disease recurrence through improper or complete treatment. And as practitioners, I think we need to be aware of what's out there, and we need to be able to respond to that stuff appropriately. And we need to provide reassurance to patients and their families that programmatically we have quality assurance steps that are in place to prevent these sorts of things from happening. And I think also that nationally and internationally, the community has come together and has started to think in a harmonized way about how we provide care to patients at all levels. This is really interesting to think about in the developing world. You can take it to an entirely other level, and when you start thinking about how we actually improve radiation services in low and middle income countries, which is also coming along and is growing in interest around the world. And CARO and ASTRO and a number of other organizations have outreach programs into Africa, sub-Saharan Africa, for example, thinking about how we deliver care there. And quality assurance in those environments becomes increasingly more challenging. What do patients want to know when this sort of thing happens? Well, they want to know a few things. They want to have an explanation provided with them. They want their practitioners, their doctors, their healthcare team to sit down with them and explain what happened. They want an apology that it happened, and they want to understand why it happened, and they want some assurance that there are appropriate steps being taken to assure that it won't happen again to other patients. And this comes from the Patients for Patient Safety Canada, a document that was published not long ago. Again, it's a very interesting read for people who are dealing with treatment incidents and those sorts of things on an ongoing basis. And they also define sort of this pathway to how one would prepare for these inevitable incidents that do happen, how one responds to them as a program, and the kind of feedback that's provided to patients, and more broadly to the rest of the radiation treatment community. I think one of the things that is becoming increasingly evident and is becoming increasingly important is that when things go awry, when an error happens for whatever reason, it's something that we need to be more open about and speak more openly about as a community. We can learn internally from something that happens here at Princess Margaret. We can actually change our policies, our procedures, as we might have for that case I showed you earlier. But the question should also be, can someone else benefit from that experience? Can someone benefit from what happened here and learn from that experience and prevent the same sort of thing from happening elsewhere? And I think in that context, we all need to come together and start thinking more openly about it. And these are just an example of the kinds of analyses that are possible. This is something that Jean-Pierre published a few years ago, looking at the rates of incidents and near misses in our program. I think that virtually all radiation treatment programs in Canada now have some kind of incident reporting system that's like this. I know that it varies dramatically from center to center across the country in terms of how incidents are documented, what incidents are documented, the types of incidents, how they're analyzed, how they're reported, those kinds of things. And I think on Friday I'll talk to you about national strategies for harmonizing that kind of approach. But it is very important to recognize that incident analysis is one element of a quality assurance program. It's also important to really understand, I think, at this point, what the cause of most of the incidents are that we see in our radiation treatment programs. And we all think about, and I've talked about, the complexity inherent in our patients, our technology, our processes, all of those sorts of things. And it's attractive to say that because of the complex equipment, that a lot of it can be put back on the equipment and the sorts of problems. In fact, the equipment performs as it's supposed to perform in 95% of circumstances. The equipment is not the source of the errors that we see in our programs in most circumstances. And this is really thanks to the manufacturers who have developed very good products that we're all using, but also to the medical physics community who have developed test protocols, quality control protocols that, when applied, assure a high level of performance of our equipment 95% of the time. In fact, the sources of problems in our programs are much more in relation to things like policies and procedures not being followed appropriately, or not available, or miscommunication, not talking. That interprofessional component of how we communicate with one another, how we trade off information, how we do patient pass-offs, those sorts of things, handoffs. And these are the two areas where I think there's a huge amount of possibility to improve our programmatic performance. At the end of the day, though, in order to prevent errors from happening and assure a high-quality program, we need multiple checks and balances embedded in our individual programs to assure that errors, if they do happen, are caught before they actually reach the patient. And this concept of system resilience, I think you'll hear more about over the next few days as well, and how we can do that at various steps along the way, from the initial imaging phase through contouring and planning, all the way through the treatment delivery, and the checks and balances that are important in doing that. There are things that have been defined that actually, in broad terms, help improve system resilience, and this is something that many of you will have heard of called the hierarchy of effectiveness, which really defines, again in broad strokes, the kinds of interventions, the kinds of checks and balances that can be embedded in a program to help prevent errors and improve resiliency, help improve how the system performs. And it's interesting that the most effective are the kinds of electromechanical things that can be built into our equipment. So interlocks, for example, that prevent certain things from happening if other things haven't already happened, to assure that it's safe. There's a limited scope of that. I know that we're getting better and better at that. I know that we're trying to build more of these controls into the hardware and software that we use all the time. But at the end of the day, the complexity of what we're trying to do, the complexity of our patients, the individualized nature of our patients prevents, I think, interlocks from being the solution to our problem entirely. And we really need to focus on some of these other aspects here, which include things like simplification and standardization of how we deliver care, checklists and reminders, policies and procedures, and education. And these are more program structure and program processes that we really need to address. I think they're less effective overall in how they work to prevent errors from happening and propagating through the system, but they're probably more targeted at the kinds of issues that we're going to have to face given the complexity of what we're trying to do. So if we think about that, how we can actually improve system resilience at a programmatic level, we can break it down sort of individualized cancer programs and how we can do that, the kinds of things that we think about at Princess Margaret, things like policies and procedures and assuring that they're followed, things like incident learning, so learning from the kinds of mistakes that we make and improving our system to prevent them from happening again. I think peer review is huge, and this is the concept that I, as a radiation oncologist, am not the only one to define a volume. That I draw my contours, I define a target volume, it gets looked at by my colleagues in a critical way before it actually goes on and the patient is treated. And in fact, the GYN peer review rounds are happening right around the corner as we speak right now. So my colleagues are there looking at my plans in my absence, and they'll send me an email telling me what I did wrong or why did you do that, that's stupid, you need to fix that. And that's very valuable, I think. And in fact, in our environment here, it's not just radiation oncology peer review anymore. It's treatment team peer review. So in the rounds there will be radiation oncologists, medical physicists, and radiation therapists, including the brachytherapy team, all sort of engaged in the discussion around how we deliver these plans. But I think we can take that to the next level as well and say, we can support our individual cancer programs nationally by providing overarching guidance for how we do these sorts of things. And this has not previously been done in Canada, or for that matter, I think in many jurisdictions around the world. People adapt and couple things together from various sorts of guidelines and standards and indicators, but I think there's a real value in actually bringing that together in a harmonized way, engaging the treatment community and developing guidelines and indicators, for example, that reflect the views of the people who are out there practicing right now. And we've started to do this in Canada, and I'll talk more about that on Friday to you. There are communities of practice as well, where people come together with similar interests, people come together who have similar interests and work together to achieve a common goal, for example, in head and neck cancer or gynecologic cancer. I think clinical trials actually are a great way of harmonizing practice. So a clinical trial, a randomized clinical trial put together by the top thinkers in a particular field usually has a radiation protocol, treatment protocol embedded in it that reflects best practice. And by participating in clinical trials, I think that actually drives that sort of best practice out there broadly into the community. National incident analysis and reporting is going to be very important, the concept of sharing our mistakes and being open enough to do that. And of course, education and advocacy. So in Canada, we've kind of broken that down to think about this in 4 major ways, really, and to define tools to drive quality assurance nationally, filtered down to the individual program levels. And we've broken it down into programmatic performance, what has to happen at the level of the cancer program to assure high quality care, equipment performance, what tests and things need to happen every day, every week, every month, to the equipment to be sure it's always performing in an optimal manner. How can we learn from our mistakes, which is the incident analysis piece. And we've wrapped this all around a focus on the patient perspective. So the patient has to be at the center of all of this. We're not doing this because we can. We're doing it because we want to improve the experience for our patients and be sure that they're always treated in an optimal manner. So this is really reflective of the strategy that the Canadian Partnership for Quality Radiotherapy has undertaken over the past 5 years or so. And as I said, I'll summarize that for you in more detail later on in the meeting. But to summarize this talk, I think in my own mind, and I really believe that we as practitioners have an obligation to provide the highest quality and safest radiation treatment to our patients. A culture of quality and safety is really essential at every step of the radiation treatment process and has to propagate through every aspect of what we do. And an effective quality control program is required to assure robust technology and programmatic performance. And that really implies successive layers of defense along the way from the decision to treat until the last fraction is delivered. And it's certainly not all about incident reporting and incident analysis. That's one important part, but there is all of the prospective quality assurance that needs to happen to assure optimal system performance, which you'll hear about. And again, I just want to emphasize again that there's an opportunity for us to learn from each other as we go forward, to really understand best practice in various centers and jurisdictions and harmonize this in a way that rolls that out across the country, and we'll talk more about that on Friday. So thank you very much, and I think I have a few minutes for questions.